Good morning everyone, my name is Charlene Pink. I'm joined with me today the lovely Professor Graham Hughes, who is going to be doing another Q&A for us. He'll be answering all of your questions that you've been submitting online, both around APS. We've got some questions around COVID today that we're going to be addressing, and if you have got any more questions that you would like answered, please do submit them during the live. We will be checking up on them and trying to answer as many as we can. So hello Graham, thank you for joining us today.
It's a pleasure.
Lovely to have you with us before the lockdown. I'm sure we're all feeling a bit anxious about it, but yes, hopefully we can get some questions answered today. So lovely to have you joining us. I will just say that any donations to GHIC will be greatly appreciated. It really does make the world of difference to the charity and all the work that Graham has done so far, both in raising awareness of APS. Of course, as you all know, he is the founder of GHIC and he is the one that discovered the syndrome. So, as I said, any donations would be extremely appreciated, and you'll be able to do that over on our website. So, without further ado, we'll get through to the questions. We have got a lot of them that have come in. And as I said, if you've got anything else you would like answered, then do just let us know during the live stream. So, the first question is from Jan. I believe she posted this last time, actually, when you were here previously for the Q&A, and we said we'd get round to it this time. So it's around COVID, and I'm sure she is of the opinion, as many others are, that they're concerned about COVID and the outcomes for APS patients is quite a worry for them. In your opinion, should they currently be shielding?
I don't think so, especially. So far as we know, there's not been an increased chance of getting ill from COVID if you have antiphospholipid syndrome. The big worry, for me anyway, is that one of the features of the patients who are quite ill with the COVID is thrombosis. So much so that most centres dealing with COVID emergencies give anticoagulants as well. So the obvious question for me, and I'm sure for you, is are those patients who are getting thrombosis patients who have underlying clotting disturbance? I used to think there was no evidence for this, but apparently there is a paper coming out soon in one of the medical journals that suggests a few of those patients getting clotting during COVID are positive for antiphospholipid antibodies. I'll pass the buck on that to my colleague, so when he comes round again, Arvind Kaul,
yes.
He, working on the COVID ward in his hospital, be able to know if that paper's out yet, and if there is. Sorry, to cut a long answer short, I don't think there's any extra risk for people with antiphospholipid than from the general population.
Thank you, Graham. So yes, as Graham mentioned, we will be doing another Q&A with Arvind next month, and he's probably going to be answering a lot more questions around COVID that you might have, so we'll be ready to welcome him then and kind of get an extended answer. But definitely for the time being, the government haven't reintroduced shielding. Obviously it's still advised to be taking the precautions we all have been all along, you know, making sure that we are washing hands and keeping our distance and doing everything that you can to stay safe, but at the moment it seems that there is no urgent need for additional shielding measures as such. Perfect. So we've had another question around COVID come in. This is from Claire Harris on Facebook. She has said that I have noticed the symptoms of long COVID seem to be similar to APS. So I'm sure we're all aware that long COVID kind of is for people who are experiencing symptoms over a prolonged period. So for many people it will be quite short-lived. They might recover within a few weeks, but for some people they are experiencing symptoms possibly even up to 6 months after contracting the virus. So Claire asks, does the professor have any thoughts on this? Could treatment for long COVID symptoms be the same as treatment for APS symptoms?
Well, that's a very good question. I totally agree with the sentiments behind this question. Yes, you're right. Some of the features of long COVID are those that we see in the antiphospholipid syndrome, and they relate to circulatory changes, the brain not getting enough oxygen, what we call Raynaud's, the cold white fingers. Those are all features of long COVID, and yes, it may well be that the mechanism is rather similar here, that there has been a lack of perfect circulation in some of the organs that have been affected. To my knowledge, there's no big positivity in antiphospholipid tests in long COVID patients. It's an obvious question to answer, and I don't think it has been shown that it's antiphospholipid alone.
Okay, brilliant, thank you. We've got another question around COVID. saying, this is from Gillian Sinclair. She has said, I have other family members with other autoimmune diseases who have received letters from the NHS advising them to take vitamin D supplements. Should APS patients be doing the same?
I think vitamin D has become the big star of medicine. It seems to be vital to protect against immunological problems. Certainly in the old days when we were looking at vitamin D in lupus, it was almost universal for them to have low vitamin D levels. And colleagues of mine working in vitamin D, first of all, take vitamin D themselves because they're so convinced. And secondly, there is evidence that it's fairly harmless. You really don't overdose it. Most normal packages give you the right instructions. But vitamin D does affect immunity. So yes, I think it's one of the things you can be on the safe side with.
Okay, so it's the case of not necessarily having to take them, but there would be no real harm in if someone did want to kind of increase their vitamin D intake at this time, either via supplements or kind of via just high vitamin D foods and such.
Yes, absolutely. I mean, you can get a vitamin D blood test if you really are keen or your doctor's keen, but on the whole we don't need that routinely.
Okay, great. So that's another thing. I think that's definitely something we'd all be considering, even non-COVID times, just for the winter season, kind of making sure we're all keeping our immune systems kind of up to scratch and the best they can be. Brilliant. Well, as I said, we will be addressing some more COVID questions when Arvid comes in next month. If you do have any other questions around COVID, do comment them on the live stream and we can get to them a bit later on. But for the moment, we've got some questions around pregnancy. Now, I know, Graham, that this is something that you've spoken at quite depth about, and you've kind of said previously about the higher chances of miscarriage and things as such. So it's something that I think you're quite keen to talk around this area. We've had a question come in from Lucy, and she firstly just says, thank you so much to Professor Hughes for taking the time to do these Q&As. It's absolutely amazing that we're able to reach out to him from around the world with questions our doctors are struggling to answer. So it's absolutely lovely. We're so grateful that you're able to do these Q&As with us, and it really does just make the world of difference, I think, for people who are struggling to find answers due to the kind of rarity of APS, and a lot of doctors maybe don't know the disease as well as they should, so it's great that we're able to hold these Q&As. So her question was, in what circumstances should a woman with APS be advised to not become pregnant?
If she's known to be APS, if she's had the disease or symptoms or clotting problems and is positive on the tests, she should be seen when the pregnancy test comes positive by physicians and obstetricians who know about this. And we started a centre at St Thomas's Hospital years ago looking at what we called then the Lupus Pregnancy Clinic, but that was mainly lupus patients. But of course it rapidly became overtaken by the Hughes syndrome, antiphospholipid syndrome. So they should definitely seek advice from doctors, obstetricians and physicians who specialise in this. What should they do? Certainly the old days, they should not be advised against pregnancy if that's what they want. I think there's every reason to be very firm on that unless there's some structural or other unrelated problem. So what happens? The young lady gets seen in the antenatal clinic or the advice clinic by a midwife or a doctor and it is tested. Now, it's until recently not all hospitals even tested for APL, which is really amazing to me because it's been going now for, was it 34, 35 years. That is changing. I think, you know, one of my jobs is as editor of the Lupus Journal, and we're getting more and more papers on research in the Hughes syndrome, which is encouraging. So they get tested. If the test is positive and they have not had an abnormal pregnancy history, many doctors advise just carrying on normally. I'm a little bit proactive myself. I think unless there's an obvious indication against, then aspirin, low-dose aspirin, 75 milligrams daily, has been shown to help, not definitively, but statistically, the number of successful pregnancies. I know that patients often are not tested until they've had 3 or more failed pregnancies. And this is one of the big tragedies of the antiphospholipid syndrome. You know, if your own wife or daughter was was pregnant and there's a hint of anything to do with Hughes syndrome, such as migraine, you'd want to be tested. Why have 3 pregnancy miscarriages?
Yes.
So I've written down, I don't know how many people know this, but I think there should be a standard questionnaire by the midwife or doctor on the first visit. And that question is, number 1, have you had a previous miscarriage? Number 2 is, do you suffer from migraine? And the third one is, do you have a family history of what we call autoimmune disease? And that includes rheumatoid, lupus, multiple sclerosis, and particularly thyroid. They run in families. So those 3 questions will help push a doctor on towards testing for antiphospholipid syndrome.
Okay, great. So we've also just had another further comment from Lucy, who's watching us live. Hello, Lucy. Thank you for joining.
Thank you.
She's just said that she's been told that women are not tested whilst pregnant. So this is not before they become pregnant, it's whilst they are pregnant, as this can affect the result. Do you know anything about that, whether there's truth in that?
I don't think so. There are odd cases, but that's wrong.
Okay, thank you for clarifying. So we've also had another question around pregnancy. It's clearly a topic people are keen to know more about.
Yeah.
Jenny says, is it possible for APS to only be present during pregnancy? Lots of specialists will not test for antibodies during pregnancy. That's what we've just said. She's kind of come across that as well. Or shortly after miscarriage, so I'm worried in case I have undiagnosed APS.
Yes.
In your opinion, should she push further then to get tested, even though some specialists are refusing to do so during pregnancy?
Yes, I think so. What I've given to the charity is a list of symptoms. I think there are 40 on the list. And if you add up to 10 of those or more, it really is a suspicion of the Hughes syndrome. I know it's rather difficult to put these lists on paper, and every patient is different, but you could test at any time, including pregnancy.
Okay, great. Thanks for clarifying. So, as Graham said, he did give us that big list of symptoms, which you can find on our website, and there is kind of a scoring technique to it. So each different symptom has a different number of points allocated to it based on their importance and relevance in APS. And you can actually go onto our website, the GHIC website, and kind of do a checklist yourself and see which symptoms you do match. It's by no means a full comprehensive list, and you should always speak to your individual consultant or doctor, whoever you're dealing with, to kind of get a more official diagnosis. But this will just give you a rough idea if your symptoms do match up, or if you score highly on the point system. So for example, 10 out of 50 on the point system is a kind of possible suspicion of APS, whereas if you scored higher up in the 20s and 30s, there'd be a strong suspicion. Yeah. Is that correct?
Yes, it is. I'd like to play down in some ways the importance of this list. You know, the patients out there that you don't know or haven't seen could go to a list like this and say, oh gosh, I've got some awful disease, and I'm in 2 minds about it. I put it in the charity because I think there are patients very much on their own who need help, and people can throw that list back at me and say it's not very sensitive or specific, but we'll see.
Yeah. Okay, great. So that's kind of our questions on pregnancy. So we will have some more information upcoming on the website and things, so do keep an eye for more on that. This is also a good time for me to just say that this video will be put onto our website as well. So if you've not been able to watch the whole thing live, or you're not able to still tune in for the rest of it, it is available on the website. Will be in a few days, and we'll also have the transcript as well as all the previous Q&As that Graham has so kindly done for us. They are available on the website for you to re-watch.
I should say that the history of pregnancy in the antiphospholipid syndrome has been staggering. Before patients were tested for this syndrome, the failure rate, the success rate rather, in pregnancy in patients with antiphospholipid was less than 20%. It's now over 90% in most big centres. So that's totally revolutionised looking at early pregnancy.
Okay, Graham. Would you be able to talk a bit more? I'm just having some camera difficulties going to get my camera up and working. Just around the kind of research that has been done thus far. You said there still needs to be a lot more work done around the miscarriage and the pregnancy side of things.
Yes, the reason for the failed pregnancy was originally thought to be clotting in the womb, clotting of the blood vessels to the baby, and the infant in the tummy doesn't get the oxygen required and the patient miscarriages. That's probably true mostly, but there are probably other mechanisms as well. These antibodies can mess up other parts of the placenta and supply of blood to the baby. So what's been very striking in experience has been that the combination of heparin, which is an injection, and baby aspirin during the pregnancy months has been the best solution for those women who've had bad medical histories. There is another thing we haven't talked about, and that's late miscarriage. Most miscarriages are at 3 months, but late miscarriage, which an article once in the Times put down as the greatest tragedy known to man, which is losing the baby at 8 months or thereabouts. We now know, as you might expect, that antiphospholipid syndrome is linked to stillbirth. Not dramatically like early pregnancy loss, but there is a link. It's about twice the chance of stillbirth if a patient's not on anticoagulants. And that's another strong reason for testing early in the pregnancy, to find a woman who's had half a dozen miscarriages and then later a stillbirth is just medically not acceptable these days. Patients should be monitored for that. So that's been another great thing for us anyway, to see this success.
Okay, fabulous.
Are we live still? Or?
We are live. We're just having one of our cameras seems to have gone off, so we're going to have to make do with just the one.
Okay.
But no problem. We've had another question come in from Kathleen, and this is around side effects and symptoms. She says, my mother was told that she has had a silent stroke. The professor previously diagnosed APS on symptoms, as there is a very strong family history of APS. Her current doctors are reluctant to lay the blame at the feet of APS, as she has had negative blood tests for APS. She also has lupus, which is in remission. What advice does the professor have in this situation?
I must say the clues are there, aren't they? It does. The fact that she's had lupus, 1 in 5 lupus patients have got features of APS. That's the current teaching to med students. So a positive history would worry you about this being a clot rather than any other thing. But as age increases, there are other causes of stroke, obviously, major causes, blood pressure, abnormal blood vessels in the brain and so on. But coming back to the history, which is so important, the feature, the previous doctor diagnosed it, okay, the tests are negative, but it's something we'll come back to a little bit later.
Okay, fabulous. And then just another question in terms of side effects and symptoms. Marianne firstly says, greetings from Finland. So it's wonderful to know that we've got a global audience. Everyone's tuning in from around the world. Marianne said, when my INR drops under 3, I get difficult memory problems, pins and needles and numbness in limbs, sometimes balance problems and headaches. Recently I was diagnosed with mild sleep apnea. Can it make these symptoms worse because of lack of oxygen?
Yes, very much so. It's very interesting, in the days since we've been using Warfarin as an anticoagulant, the INR, some of you may not know this, but the INR is the ratio. Think of it like Tesco's milk, you know. Ratio of 1 is normal milk, ratio of 2 is half cream milk, ratio of 3 is pretty well skimmed milk. You need, if you have brain problems with APS, and you're needing warfarin, to monitor carefully. The routine use is up to, let's say, about an INR of 3. But a lot of patients and doctors even are scared of that. They think the dangers of bleeding. The dangers of bleeding on warfarin statistically have been well worked out, and they are 4 or over. So this lady clearly is getting problems when INR is below 3. My normal advice, if you can get it, is to get your own INR finger prick testing machine, and to collaborate with your clinic. Remember that the antiphospholipid syndrome is a much more clotting disorder than many of the other reasons for giving warfarin, and it's very common for us to see a patient who headaches and memory loss return when the INR is, say, 3.2, instead of 2.8. So it's as fine as that, and your patient in Finland is absolutely correct with this observation.
Okay, very interesting, thank you. We've also had some questions kind of around the medication side of things. So this first one comes from Dee, and she says, does APS and lifelong warfarin increase your risk of getting a blood cancer, like polycythemia?
The answer is no. Blood cancers not linked to this disease as far as we have found out so far.
Okay. And then in terms of another question we've had come in from Mandy Harrison, she says, hello, I've been told I can't be tested for lupus because I'm on rivaroxaban. Is this correct?
Wrong. The
So
test for lupus is a separate test.
Okay.
Anti-DNA it's called.
And the medication has no bearing, it will not give a positive outcome on,
No.
or a negative outcome on the test won't
No.
impact it.
No.
Brilliant, okay. So we've had another question in come around medication and different treatment. So this one is from Mavis. She says, I've heard about a drug called diprodimol. Could this be used to treat APS? Have you heard of such
No, pass. I think it's one of the family of anticoagulants, and I've no experience with it. We get quite a lot of questions about the new oral anticoagulants, and I can speak to those if you like in a minute.
Brilliant. It will, it'd be great to get some more insight on that and see whether it could possibly something or whether there's no use in that. So we had another one from around the world. So Kelly says, hello from Texas. And she has actually made your acquaintance already. She says, you were kind enough to co-consult on my case along with Professor Jordan in 2016. I've continued to clot through multiple anticoagulation regimes, including enoxaparin, warfarin, and she is now on ritomixabab. Yes, she says fondaparinux has been suggested as a possibility. She says some APS patients seem to do well on it, especially those with neurological aspects like her. She says, I failed Dr. Jill Schofield's apixaban trial. This was documented by scanned DVTs, migraine, seizures and TIA symptoms. She asks, how is fondaparinux any different than apixaban? Does it have any specific advantages?
Not to my knowledge, but they may be wrong on that. Let's discuss treatment briefly. There's two drugs being mentioned here particularly, rituximab, R-I-T, rituximab, and the anti-clotting drugs. Rituximab is a fabulous drug. It's been around now for diseases like lupus, where the immune system goes mad, goes overboard. And rituximab is one of the new monoclonal antibodies, the new wonder biologics, if you like, that's been found to be very useful in lupus and in other autoimmune diseases. For very severe cases of Hughes syndrome, where the clotting seems to go on despite anticoagulants, there has been trials of rituximab, and we've used it in a small number of patients ourselves with mixed results. In some patients there's been clear response. The immune system is calming down on rituximab. But as yet it's not the great drug that we'd hope for in the antiphospholipid syndrome. Mm-hmm. Concerning anti-clotting, that's the main treatment, is something that makes the blood thinner. First of all there was aspirin, then there came heparin, and then warfarin. More recently we've had anti-clotting drugs which have been marketed and have been very exciting for us. Sadly, I think the truth at the moment is that the overall results haven't been as good as expected. And the trials are going on. There's a big trial here in London which showed that for people getting stroke and other major diseases, they were not as effective in general as warfarin. So I'm afraid it's still watch that space as far as these drugs are concerned.
Okay, yes, it's very interesting, and as we've said before in previous Q&As, things may well change in the future,
yes.
But it's constantly something that we hope is going to be looked into more, and it could always be a case of different circumstances in the future. Jenny asks, when should immunotherapy be considered to lower APS antibody levels?
Yes, that's the question I was answering in the previous talk.
Yes.
You know, high antibody levels means that there's something wrong with your immune system. And APS is one example of disease where antibodies mess things up. You'd logically think that immunosuppression would be the right treatment. But as I said with rituximab, the results have been mixed. It's not the prime. But if you're desperate, if the patient and her doctors are desperate, this is one line of approach which is being taken.
Mm-hmm. Okay, interesting. And Sue has commented, Sue Perry, thank you for your question. She says, I was off Warfarin and on a Pixaban for a year. She had some problems on it. She doesn't know whether it might be related or a coincidence. Her symptoms kind of include some new pain, increased facial tightening, light sensitivity, struggle with memory. Lots of symptoms we've talked about before, and one seizure episode as well. She says on Warfarin her target INR was 1.7 to 2.5. She requested that to be increased and it is now 2.5 to 3. Might her symptoms be helped with a higher INR, do you think?
Yes, definitely. You know, assuming there are no other contraindications. When a patient walks in the room and says, I'm on Warfarin, but I'm still getting headaches, memory loss, balance problems, speech disturbance, all brain things, then the first thing I do is, can I see your little booklet which has your INR in it? And then you read out 1.9, 2.8, 3.4. That patient is not getting treated properly. And she's picked up the fact that the symptoms of Hughes syndrome are returning, whatever the drug is, but with Warfarin you can monitor it. And the INR in her case is not good enough.
Okay, fabulous. If you're able to move to the right a
I'm
little
okay,
bit, that
thank
would be
you.
great. Okay, so Linda has asked, can any genetic testing be done whilst on Warfarin?
I'm not aware of any. There have been genetic studies of APS to see, you know, if there's a gene that figures, as there are in lupus. I don't think that any genetic helping has become routinely used. I think I would have heard about it, I hope so anyway, but it's not, unfortunately. I hope I'm wrong, because I hope that will come in the future. But it's definitely a genetic disease in that there are family histories which are very strong.
Yes.
But in terms of strength of your genetics, it's not that strong.
Okay. Interesting. So it's kind of the situation where, it is possible, but not as strong as, say, another disease. Okay, interesting. So we'll kind of go on to our next topic. We've had some questions around diagnosis and testing. So Marie has asked, after having a history of dialysis and having 2 kidney transplants, I was diagnosed with APS this year after having a clot and a lupus flare. Would you say that is rare considering her medical history?
No, I don't think so. I think any form of lupus can be associated with this. We don't know in her case, do we, whether she was tested for APS early on. It's a routine test now in any lupus clinic to have sticky blood, because come to think of it, many of the features of that lupus may not be just lupus but APS. The miscarriages, the clot, the DVT, the memory loss, even, I hate to say it, the stroke that some people get is more likely to be from sticky blood than lupus.
Yes. Okay, very interesting. And then we've had a question again around kind of testing. Sanjita has said, if someone has raised APTT with normal PT, increased platelets, should they be tested for LA with other factors? Could you suggest anything else? This is especially considering that they've got occasional chest discomfort and shortness of breath.
Yes, we don't know how high the platelet count is there, do we?
No, we've not got a number here.
It sounds a different story. The platelet counts in APS are normal or low. They can be very low occasionally. That cause bleeding, which is a horrific combination. So it doesn't sound like APS, but certainly that combination, hopefully a hematology colleague is looking after the patient and is going through other... There are other clotting disorders, I should say. There is one where you have very high platelets, and they can cause clotting. But that's a different scenario.
Okay. Sanjita, thank you for watching. She is live watching us at the moment. She's also just posted another question and said, is there a severity of APS? So does DRVVT being higher than the last blood test indicate APS is worsening?
Not to my knowledge. let's take the simple test for APS, the anticardiolipin or antiphospholipid is the terrible word for it, APL.
Yes.
Some patients call it the Apple test, APL. Yes, it can go up and down, and it does. And then we see patients over the years, rarely, but it does happen, the antibody disappears totally. And that answers a number of questions in patients. There are patients who have the whole figure of the disease, but the tests are negative. And of course, they have a very hard time of it because some people don't believe that they've got Hughes syndrome.
I see, yes. And Linda has commented online, she is also watching us live, and she asks, have you seen that APS patients also have Addison's?
Yes, we reported very early on a small number of patients with Addison's. Very interesting. There was a history, was it the 50th or 100th, I don't know, anniversary of Addison describing his disease. And there was a conference in Guy's on Addison's disease. And one of my team went along to that conference and put his hand up and said, we've got a number of cases of antiphospholipid,
yes,
presumably clotting in the adrenal gland that's caused it.
Okay.
So the answer is yes.
Okay, very interesting. But you wouldn't say that that's something that's particularly common?
Rare. It's rare.
Quite
I
rare.
think I do.
Quite rare. Okay, very interesting. So yes, we've got lots of people watching online. Thank you very much for tuning in. As we've said previously, this video will be available on the website if you do want to kind of watch it back or haven't been able to listen to the whole thing. Just another mention as well that GHIC really would appreciate any donations that are able to be made. It is important, isn't it, to be able to continue the vital work that Graham started and that we're trying to continue here. So any donations would be greatly appreciated, and you can do so on the website. So we've had another question come in from Wendy, who's also watching us live. Thank you, Wendy. Wendy asks, can liver disease negatively affect APS, or can APS flare up liver disease?
Yes. The liver can be affected in APS, no question about it. There are patients who've clotted in the liver, and sometimes that's acute. It's like clotting in the kidney. So yes is the answer. Whether liver, and some patients have very mild liver involvement and have very slightly abnormal liver function tests, and we've certainly seen that. It's not very big or common a story actually, the liver, but definitely is on our textbook list.
Okay, fantastic. We've also had Charlotte is watching us live. Thank you for your question, Charlotte. She says hello from Denmark.
Oh,
so
hi.
another country we can tick off the list is currently watching. Charlotte says, I have Hughes and factor 2. Do factor 2 increase my Hughes symptoms?
I don't know that it does. I don't know the answer to that question, but
okay, possibly one we can check back.
We can check back on that.
Check back and answer.
Yeah, but
okay, fabulous. And then we've also had a question from Anna, also watching us live. Hello, Anna. Thank you for joining. She says, with Warfarin, does the INR have to be at 3? As far as my understanding is, it's different for each person, isn't it? The Warfarin dose, depending on each individual circumstance.
Yes, you're correct. If you go to a Warfarin clinic, I must say a lot of the patients attending a Warfarin clinic are little older patients who had maybe a DVT or a arrhythmia of the heart. That's what Warfarin is widely used for. But in Hughes syndrome, everyone is different. Many patients feel fantastic when they start Warfarin. Headaches gone, balance gone, memory sharper. But often we find, as I said in a previous answer, that the dose ought to be pushed up high. And the doctor and the patient working together should not be afraid of that. A patient may have total improvement, converting her INR from 3 to 3.2. It can be as fine-tuned as that. Very important to know that.
Okay, very interesting. Thank you. And we've had some more comments online. So Tracy asks, why does APS fall between rheumatology and haematology? Does it sit somewhere best in between? Is there a particular reason for that?
Yeah, all these things have more history than
Yes.
anything else. We were rheumatologists. Even I was more of a general medicine doctor than a rheumatologist. We ran lupus clinics. And it was through lupus that we discovered the antiphospholipid syndrome. So historically, rheumatologists have all been interested, but the questions, like the last question, it does need a specialist hematologist if the tests. And we do collaborate with haematologists. For instance, at St Thomas's we have a combined clinic.
Yes. Ah, very interesting. Okay. We've just had a comment from Jen. Hello, Jen. Thank you for joining in. She has asked, she just said, sorry if I missed the question, if it's already been asked. She asked about INR levels. We did previously answer that question, Jen, and we said that INR is different for each person.
Yeah.
There is no kind of one set level. It really depends. Each person's Hughes syndrome is different. It can impact them differently, and thus your INR is going to be different from someone else. So it's best to kind of talk to your individual consultant on that.
There are patients who really tell you a lesson. I've got one lady, she comes from Oswestry. I shouldn't give her name away, of course, but she's been INR 4 for the last 2, 3, 4 years, completely well with no symptoms, previously getting regular seizures. So that's a high level, but you know, some patients do require, for reasons we don't understand, a higher INR.
Okay, thank you. Very interesting. We've had a question around also kind of symptoms and more side effects. We've had someone say that they are suffering with migraines, movement disorder as well. She's had several attacks this year. Also sometimes talks gibberish through an attack.
Yeah.
Is that, would you say that's quite common and
definitely
apparent in the syndrome?
Yeah.
You've previously spoken quite at length about migraines as well, as being one of the most common.
Movement disorders, tics, jerks, balance problems, they're all brain things, and it's the brain that seems to be most sensitive to a lack of oxygen.
Yes.
But the movement disorders are quite interesting. I had a lady with severe tic going back many years with the arm jerking like this, and gone now on anticoagulants.
Oh, okay. Was there a particular anticoagulant that she was on?
No, it's Warfarin.
Warfarin.
If the brain is involved, historically anyway, we've tended to go for safety with Warfarin.
With Warfarin.
And although the media don't like Warfarin, as I said, the fact is it's the one drug which the patient has control of her own dosage and body.
Yes. Okay. Linda has kind of picked up on different side effects and symptoms and said, are headaches and kaleidoscope vision more common with APS or with lupus?
No, APS more than
APS
lupus.
more than
yes.
lupus.
And if you have a lupus with visual problems of that sort, you really have to test for APS because the treatment's different. Lupus, steroids, etc.
Yes.
APS not.
Different treatment. Yeah, I think that's very interesting. We have also spoken about how some people are actually misdiagnosed at the start, and they could actually be thought to have even like MS is also related, isn't it? Or lupus, and then turns out to be
it's not
APS.
surprising. If you think of a patient with balance disturbance, visual flashings, loss of vision in one eye, pins and needles in the arms and legs, MS is likely to be high on the list of possibilities. But they're also high on the list of Hughes syndrome. And we certainly in my clinic have seen a small number of definite patients who were attending MS clinics who are now free on anticoagulants.
Oh, great. Thank you everyone for tuning in again. We've had a comment from Susan. So Susan has actually said, is it possible, can I have APS with sarcoidosis? So this is interesting actually.
Yeah.
I believe we might have had a comment like this last time from someone, because as you know, Graham, we're involved with sarcoidosis myself.
Yeah.
Is it possible that you can have kind of both?
I've not come across it, both rare diseases. One possibility, and I'm just whatever the word is, hypothesizing here, is that sarcoid has many features in common with a disease called Sjögren's, which is a relation of lupus. So misdiagnosis does come into it, as sarcoid patients will tell us that they've not been diagnosed. They've got big glands and so on that Sjögren's get. I've not in my whole career come across that combination.
Okay, yeah. So
it's worth.
Interesting. Thank you for explaining that. We've had also a comment coming from Wendy. Thank you for tuning in, Wendy. She has said that her mother's vitamin B levels have shot up. She said it's shot to 1,107, should between 107 and 443 the last time. She asks if the increase in vitamin B could cause an APS flare-up, or could it aggravate the APS in any way?
I've not come across this at all. We do measure vitamin B if any neurological features are there, of course. And I don't know of it being published as a study that it's effective. I think the answer is no.
Okay. Thank you. And Ali has asked as well. Thank you for joining in, Ali. She's commented live and has said, can you tell me if aches and pains in the joints and the muscles, if these flares are caused by Hughes syndrome or fibromyalgia? So it appears she suffers from both, and is kind of, it might be hard to tell which one it's coming from. Is that correct? Well,
I'll tell you my prejudice here. I think if a patient with Hughes syndrome gets fibromyalgia-like symptoms, they should be investigated. There's a danger, I believe anyway, with fibromyalgia being a kind of bus stop. Doctors don't go any further than giving a label. What does it mean? It means you've got aches and pains, really. And you could well have associated mild lupus or mild Sjögren's. Those are the two we see very commonly. So yes, it's a feature we see in a new patient coming up. We test for dry eyes. Does the patient have tear impairment, which is a feature of Sjögren's? Allergies, rashes, all the features of what we call mild lupus, which is often very responsive to quinine, of all things, plaquenil, hydroxychloroquine, tonic, like gin and tonic, but a bigger dose as a tablet. Very, very effective in the aches and pains situation that we see, as I think this lady has.
Wendy also, just to follow on to her previous question that we asked from Wendy, she says, do low levels of hematocrit, red cell count and MCV, so low levels of that, does that aggravate APS? Is there any treatment for that?
Yes, well, the low levels, hemoglobin is a straight anemia, but other levels, did you say the red cell count? I forgot what the other one is.
Red cell count and MCV.
MCV is the size of the red cells.
The size, okay, so one is the
volume.
count and one is the size.
Yes, and there are things that make the red cells go bigger. They need investigating. A normal red cell, say 7, I won't go into actual measurements, if it goes up 10 or 11, there are things that cause it. One is allergy to certain drugs, so you need to investigate that lady.
Yeah. And again, that could be different per person. Obviously, everyone could be affected differently. If people have different allergens and so on.
Well, med students have to learn a dozen or 15 causes of raised MCVs. It's an important observation.
Yeah, definitely. Okay, so another question from Sanjita. She has asked, can general infections flare up APS?
It can be disastrous. It's one of the things that we've seen. The patient's fairly stable for a number of years on anticoagulants, goes down with a bad infection and everything out of kilter.
Yes.
There's a very rare condition called catastrophic APS, which you may have heard about, which is a good description of it, where your blood clots in different organs of the body, intensive care treatment, and can be fatal. And that's thought to follow a severe viral or other infection. This was something we thought we might see with the COVID pandemic, but I don't think it's quite come out that way.
Because a lot of people, some people are commenting live as well who might have missed the start of the video and are asking if they are more susceptible to COVID, but perhaps our understanding at the moment is they might not be more susceptible to it, but if they were to catch it, then the side effects from it, that they might be impacted in a different way or in a more severe way to someone who didn't have the syndrome.
That's right.
So yes,
you're not at increased risk from catching COVID.
More from if you were to catch it,
then you've got a clotting danger.
Then it would be an increased risk. Yes. So I think that's an important one to note. I know obviously a lot of people, as I said, have been concerned about COVID, and as we said previously in the video, if you missed the start, we're just suggesting that you take your precautions that you were, and kind of shielding hasn't been recommenced. It's just obviously the national lockdown as of tomorrow, but making sure that everyone's keeping themselves safe, but you're not necessarily at an increased risk.
Sure.
Brilliant. We've had some more people comment from around the world. We've got people tuning in from Switzerland, other parts of Europe, from Australia as well. Hello to everyone. Thank you so much for tuning in. It's greatly appreciated. Jenny asks, so Jenny is from Australia and says, thank you so much for the opportunity to ask Professor Hughes a question. She asks, can APS cause positive anti-nuclear antibodies?
It doesn't cause anti-nuclear antibodies. That looks other autoimmune diseases. But as we said in the last question, there's a risk of association with other autoimmune diseases like thyroid, Sjogren's, lupus, and it's quite common for us to have APL patients positive with a positive anti-nuclear. A lot depends on how strong that level of antibody is.
Yes.
If it's 1 in 40, forget it. But if it's 1 in 200, well, maybe that patient's got aches and pains and a few other overlap features of Sjogren's.
Yes. Okay. And Ali has said, thank you for answering my question. So we answered the previous one of hers about the aches and pains. Just following up on that, she's commented live and said that her doctors took her off Plaquenil about a year ago. Regarding the pain, could it be worth going back onto it, do you think?
It's a difficult one to answer a specific question like that. I'd be in big trouble if I did, I think.
Yes, of course. We do. I'll take this moment to just say we do. This is obviously a kind of rough guide, and we use it more to give general advice. Obviously, if there are very specific questions, you do need to speak to your individual consultant or doctor.
Yeah. Well, Plaquenil is a fabulous medicine. Fabulous. It's got a high degree of safety. The dose is, around the world, I think the dose is 200 mgs or milligrams. And that is now standard in lupus, but it's very effective for the milder symptoms, the aches and pains and fatigue. Higher doses can cause retinal damage in the eye, and that's a big scare. But the doses we advocate, which is 1 tablet a day, or even less, 3 tablets a week, often over a period of time start getting benefits for fatigue and aches and pains. Very useful to think about. And yes, maybe it's a wise idea for her doctor to think about, or her to think about going back on Plaquenil.
Yeah, definitely something to consider there.
Yeah, slow to act, takes a couple of months to build up, but it's worth the wait.
Is that the same case with other medications as well, that some can be slow to act, or are there others that you'd see kind of immediate effects?
Yes, huge variation. Heparin immediate.
Yes.
And that's why we do 2 weeks heparin test in many of our patients for diagnosis, see if their memory loss goes away. But with quinine or Plaquenil, it's 2 months or so before you get a real benefit.
So it's kind of a more prolonged thing to see the effects and that.
Well, one of the nicest things I've found in clinical practice is a patient who started on 1 a day Plaquenil, or even a patient who's worried about it, to start on 1 a week. You know, you don't grow horns. You feel better, you start taking 2 a week. And when that patient comes back in 3 months, it's so often the case, how are you doing? Fantastic. You know, my fatigue is much, much better.
Yeah. No, it's definitely great when people can kind of find the right medication that works for them and alleviate the symptoms. We've had a question come in from Ruth. Ruth says, how does factor V Leiden relate to APS? Should she be tested for APS?
No, they're separate causes of clotting.
Okay, so just for my own understanding and people watching, if some people aren't aware, what exactly is factor V Leiden?
Factor V Leiden. I think it was discovered in Leiden, in Holland.
Yes.
And it's one of the clotting proteins. Clotting is very complicated. And factor V Leiden is one of the process. And it's been found that if you have abnormal levels of anti-factor V Leiden, there is a danger of thrombosis. But it's a totally different disease from Hughes syndrome as a cause of thrombosis. For instance, Hughes syndrome can cause artery clotting, which is devastating, whereas factor V tends not to. Okay.
So that's the kind of main difference. So in Ruth's case, you do recommend that she should be tested for APS just to act on the side of caution, or is there not a particular
reason to? If it depends on the history totally.
Yes.
If she's had multiple clotting things, then there's a standard clotting screen. APS and factor V should be part of that screen.
Okay. I believe we've had a similar question to this one come in before. This is from Gemma Parks. Thank you, Gemma, for commenting. She asks, what percentage of APS patients would then go on to develop lupus? She said that she's had APS for 8 years, it's been treated with Warfarin, but she also has some clinical features of lupus, and she is described as lupus by her consultant.
Right.
But I'm not sure that we know the percentage exactly.
I should say it's very rare for primary APS to move into lupus.
Is it more common the other way around for lupus to move in,
it doesn't.
Not?
And that's one of the things should be known by patients, that if they come along at the age of 18 or whatever it is, and test positive but no evidence of lupus, in my experience of 35 years of APS, it does not move into lupus, thank goodness. This is a very nice thing to know. Or for the woman who's had multiple miscarriages. If lupus tests are negative at 18 or 20, they tend to remain negative. What you're talking about, or your patient is talking about, is aches and pains, mild lupus possibly right from the start, but APS is her main feature.
Okay. Brilliant. So we've got about 10 minutes left with the questions. I think we've tried to answer as many as we can. As I previously said, if you do have any questions that we haven't managed to get round to this time, we will be doing another Q&A next month with Arvind. We're very lucky to be joined by him next month, and we'll try address more of those, but we'll squeeze in the last few now. So Sanjita has asked another question and has said, can hydroxychloroquine reduce ESR-CRP?
Yes.
It can reduce it.
It's got a number of effects, which makes it an interesting drug from our point of view. But one of them is anti-inflammatory, and that's where the aches and pains come in. That improves.
Yes, interesting. So we've had quite a few questions today around kind of medication and things, and this one is that Sanjita has APS being treated with aspirin currently. She also says possible Lupus-like symptoms. Should she try prednisone or hydroxychloroquine first? Which one would you recommend as being the first port of call?
For the aches and pains, is that her?
Just for APS, she said she's currently being treated with aspirin, but I'm assuming, yes, she's having some increased symptoms. Out of the two, is there kind of a preference for which one to go to first?
It depends what she's got. I'm sorry to be on the fence on this one, but there's no question that hydroxychloroquine first, steroids last.
Okay.
If it's mild. And if a patient comes in with, SOS, then you may go for strong drugs first. But that.
Okay. Jen has commented and saying that she has APS and lupus, Hashimoto's,
yes.
lesions on the brain and absent seizures, currently controlled with Keppra. She says, I have 50% hearing loss and tinnitus. She does have hearing aids. Is this a symptom of APS or lupus?
Yes, APS more likely.
APS more likely.
More likely. All those features are seen in APS, and it's very serious. And presumably she's under a clinic that is dealing with APS.
Well, funny you should say that. She does go on to say that she's currently seeing a neurologist and a neuromatologist. She said she can't find a GP who understands APS, which I think a lot of people come into the same type of quarrel, don't they? She asks, should she involve a haematologist or an immunologist as well?
Yes, it depends on how much joy, if you like, she's getting from her current physicians. But she's seriously ill with the brain getting attacked by poor circulation.
Yes.
Therefore,
yes, and I think it's, as we've said, it's something quite common that people struggle to find someone who understands APS and Hughes syndrome and the effects that it can have.
Yes. I think that's why this charity is here. It really is to educate as best we can, colleagues and patients and relatives and so on.
Yes, so as I said before, any donations would be extremely appreciated. It would mean we can keep continuing to do our work, kind of raising awareness, spreading the news that hopefully people, our main aim is of course to just make sure that we can eventually find a cure and that there's more treatment available and an increased understanding for people who are suffering at the moment. So it really is of the utmost importance, and if we are able to get any donations, it would be greatly appreciated. Right, we're down to our last final minutes. I will just sneak in a couple more questions before we'll have to end the live Q&A, but thank you everyone for joining once again. We've had a question from Charlotte who says, are steroids not good for Hughes? She is currently being treated with steroid cream. She has pronunciation with this one. She has psoriasis in her ears. Psoriasis. Yes. Steroid creams are widely used for psoriasis of the skin, which is different from APS. APS itself, the clotting disorder, conventionally does not need steroids. Okay, so not for that one. Thank you. And Marion says, what is recommended for facial rash associated with APS? It can be worse sometimes with small raised bumps, mostly over the cheeks and nose.
We would tend to look at lesions in the skin. Obviously we get a haematologist involved, but our friend quinine or Plaquenil is very useful for skin manifestations of autoimmune disease. So that would be one thought for me.
Okay, fabulous. Well, we're going to have to conclude the video here. We've had some final comments from people. It seems everyone's absolutely loved the video today, Graham, so thank you so much for coming in. We've had a comment from Jenny saying this is absolutely amazing. Thank you so much, Professor Hughes. Mavis says thank you, Professor. Anne says thank you. I've learned a lot today. So everyone is extremely grateful for your time. We really appreciate you coming in. Obviously the day before lockdown, it's great that we were able to do this one more time in person, even though socially distanced. And as I said, we will be doing one more a Q&A next month to end off the year, so we'll be answering any questions we didn't get to that time. But
happy to do
both, I can only say our greatest thanks for coming in today. We really do appreciate it, and it would be great if everyone can go to the GHIC website, donate if you can, and to allow us to keep doing more videos like these.
Pleasure.
Fabulous. Thank you so much, Graham. I'll leave it at that, and thank you everyone for watching. Goodbye.